All right. Hey, welcome, Dr. Bostom. How are you?
Hold on just
Good.
one
How
more
are you
second,
doing?
guys.
We got him. We're hearing him.
Oh, you're hearing him?
Yeah, we're hearing him. We got him. Doctor, can you hear
Excellent.
us?
Yes, I can hear you.
I say hi to Mike Collins. You and I
Hi,
talked
Doc.
earlier.
Hi, good
Hi.
afternoon, doctor.
All right, Doctor. So we've just been talking about, we're bracing for an announcement from the governor tomorrow about new restrictions, lockdowns, maybe moving us back to lockdown phase 2. We're currently in phase 3.
She actually said that today? She said something about that today?
No, yesterday she said tomorrow, Friday, she's going to be announcing the new lockdown. We don't know exactly what that's going to look like yet. But I'm now sharing on the screen your article about an unhysterical COVID-19 assessment in Rhode Island. And so basically you're saying that the states and the governor's response to the data is hysterical, right? So go ahead, the floor is yours.
Well, one of the things you could start with, Mike, is if you click on the link to my friend Ed Acorn's op-ed back from April 30th, maybe that would be a good place to start for people to see what I'm talking about, because there's a history to this. It's not just what has transpired since she was visited by the great Deborah Birx and set on another rampage. If you take a look, if you click on that link where it says projections, you can see the models that were produced for the state by the Department of Epidemiology at Brown University. Do you see what I'm saying? Can you click on that?
No, I don't. But I remember that we didn't even reach about 1/6 of where they were projecting we were going to go, right?
Well, basically, if you on April 27th, according to the model that the state was using, there was supposed to be 4,300 beds occupied with COVID patients.
Right.
That was the more hysterical model. The less hysterical model said May 3rd, 2,250 beds.
Right.
Actual hospitalizations peaked at 377 beds. So one estimate was 11.4-fold off. The other estimate, the more conservative estimate, was 6-fold off.
Right.
And so that sort of set the tone, frankly, for a lot of what's going on since. So here we are. We've had this long period. You have this bizarre Thanksgiving. I don't even know what to call it. Reopening Rhode Island, displayed some model robotic-looking family, not having any guests and basically social distance from each other, wearing masks inside their own home. I don't know if you have that. That's my figure 1 in that piece that you're referring to. And it's accompanied by a document in tips for a safer holiday season that says, quote, new COVID cases and deaths are steeply rising, and deaths, it says, are steeply rising in Rhode Island. And that's just a bold-faced lie. I've graphed out, and the way they gin the hysteria up is by forgetting what happened in the spring. And they never use that for a basis of comparison any longer. And what the figures in this piece show you is that deaths, hospitalizations, ICU hospitalizations, and yes, infections are down dramatically. And we had a slight uptick in infections after she put phase 3 into place. I think that was the end of June. And then we had a slight
infections
uptick.
Total or infection rate?
I'm talking about the percent positive, because that's all that counts. If you massively test people, you can't compare that to 10-fold lower or 20-fold lower or 50-fold lower testing. You have to look at the percent positives. So in my figure 4, you can see that we've come down dramatically since May. There was a slight uptick in August up to where we are. The last figures I saw for the end of last week were 2.9%. We're back at 2.9%. But interestingly, when we went up to 2.9% in August, that didn't trigger calls for going back to phase 2.
All right, so hold on. So let me clarify here. So we're looking at the curve. So we're showing right here, July to August, it went up from 2 to maybe 3%. And you're saying we've already been here, right? A few months ago, we had a similar increase to what we're experiencing now. So why now are we going to reimpose restrictions when we didn't consider it then?
The logical assumption, Mike, would be November 3rd. I mean, I don't see any other explanation for it. I'm sorry to be so bold about it, but this seems to be very political.
Mike?
Now, in her defense, there's a lot of interesting things that are going on with coronavirus. There's, at least in the U.S. and some other countries, they're finding dramatically low rates for this time of year. Now it could change of seasonal influenza. This has been a phenomenon that's been noticed before with other outbreaks, where a new virus can almost sort of replace or supersede for a period of time a traditional seasonal virus. So maybe some of that is going on. But when you look at the clinical presentation of coronavirus now versus in the spring, it's clearly a less fearsome disease in terms of the hospitalizations and deaths that are accompanying it, and that could be for two reasons, both of which are very natural and plausible. One is the development of immunity in the population, in our population here in Rhode Island and in other parts of the country that were hit hard. And the other thing that's possible is that the virus may have somewhat attenuated itself. It's really hard to say. But clearly it is not behaving with the aggressiveness that it behaved with in the spring, and that's a good thing. That's a reassuring thing. And
so we're looking at your figure 3 right now, Doctor, on the screen, where the yellow line shows a slight increase in hospitalizations. The red line shows ICU, which is a really intensive care, people really struggling, has barely gone up at all. So talk about that. And
there's a disproportionate relationship between them, and I pointed that out for a period of time. You have to look at how many of these hospitalizations are winding up in the ICU. So that has changed significantly. That there's a much lower percentage of people who are hospitalized that are winding up in the ICU. Again, that's a good thing. That's a very good thing. Therapeutics have improved. Just the familiarity with the disease has made the clinicians more comfortable treating it and figuring out what therapies might work, what approaches might work to these patients. But also it raises other fundamental questions that need to be addressed and that I was discussing in the piece, which is we're not even privy to what the admission codes are for these people besides COVID. Is it COVID with a co-diagnosis of something that reflects lung disease, like pneumonia, like bronchitis, like lower respiratory tract infection, or God forbid, acute respiratory distress syndrome, where many of those patients die? I mean, what are the conditions into which they're being brought into the hospital? Has that changed?
If I may, you did some research on this, because I guess you had access to the data in Florida. And if I recall from
it was a public report, Mike. It was a public report. So the Florida House, which is what should be done here, the Florida House reviewed about 14,000 death certificates in the state of Florida. And what they found was appalling, that the whole system had broken down. And I hold actually the CDC, the Center for Disease Control and Prevention, responsible for this, because there's a traditional way that the CDC endorsed over many decades for how to fill out a death certificate. There's two parts. One part basically deals with causality. That's part one. The part two deals with potentially contributing causes, or what we would call comorbidities. So did the person have diabetes? Did they have heart disease underlying? Did they have lung disease underlying, et cetera? CDC destroyed that firewall for some bizarre reason last spring. And what I found is that Yes, the Florida investigators pulled out the obvious ones. About 10% of those 14,000 death certificates were just ridiculous. COVID was not to be found except maybe the person tested positive in either part 1 or part 2.
You
So
found
they
something
eliminated
like
those.
40 to 50% of Florida tagged COVID deaths probably were not COVID caused at all.
Well, I estimated that you had to add about another 35% to that 10% that was just ridiculous, that just should be thrown out, because they were destroying the distinction between comorbidities and contributing conditions and cause of death. Mike, it's very simple. An ideal appropriate death certificate for someone, unfortunately, who dies of COVID is you have in part 1, it goes CBA. C is coronavirus. That's really the cause. B, it causes a pneumonia. A, the person dies from acute respiratory distress syndrome. That's an appropriate death certificate. In part 2, it could say, well, the person also had a history of diabetes, had a history of heart disease, etc.
So you're calling on Rhode Island to do a similar audit and public report.
Absolutely. Because, and it's not the state's fault necessarily. The CDC, again, I'm not a conspiracy theorist, but I have no idea why they would change this long-standing practice. There's supposed to be a firewall, a literal firewall between parts 1 and part 2. Part 1 is your causality, period. Part 2 are chronic conditions that may contribute, and they're not the same, and they're not supposed to be the same. And I don't know why this was changed so dramatically last spring, but it has repercussions for the entire country, and Florida is a good case study in some of those repercussions.
All right. So do you have a few more minutes, Doctor?
Yes, sure.
We're talking to Dr. Andrew Bostom, a nationally renowned author, epidemiologist. You got your master's degree at Brown?
In epidemiology, yes.
In epidemiology at Brown. Can we talk about, and Mike, jump in anytime, Mike.
Yeah. Well, if I may for 1 second.
Yeah, go ahead. Yeah.
I agree with a lot what he was saying, because I have a childhood friend of mine who's an undertaker. And over the last 3 or 4 months, up till like 3 or 4 weeks ago, everybody that passed away was coming in as tagged as COVID. There was no one died of cancer, no one died of this. Everybody was tagged as COVID. So,
was that unusual? I mean, I want to learn from this. Was that an unusual situation from his perspective?
Oh, absolutely. Absolutely. Matter of fact, doctor, to go one step further, whatever you died in was what you buried in. And this is how they're handling things. The embalmers in this state and stuff, they weren't even embalming people. They gave you 48 hours upon death to decide whether you're being cremated or going in the ground. And you were going in the ground in the body bag that they locked you up in and the clothes you had on.
Okay. Yeah.
And everybody was listed dying of COVID.
Mm-hmm. Mm-hmm.
Yep.
Well, it's look, there are lots of ethical and social and moral problems with this, but there's also a fundamental problem in terms of understanding this epidemic, or any epidemic. If things are going to be so lax and so biased and so crazy, how the hell are you ever going to figure out, when the epidemic ends? If it's impossible to follow things this way. And there's also a whole issue with the testing, which I got into in this piece. But to cut to the chase, particularly on the campuses in Rhode Island and everywhere, but also in the schools, it's horrific how kids are being penalized. If there's any blessing, and I use that word guardedly, if there's any blessing to this disease, compared to influenza, and I'm talking now about seasonal influenza, not pandemic influenza, it is for some reason, and there are explanations for it, it is some reason very sparing of children and young people. It is vicious in its attack on the infirm elderly, particularly the institutionalized elderly, and Rhode Island is a great example of how deadly it can be among the institutionalized elderly. But it is the opposite in the young. Right, according to the website, we don't have a person under 30 in the state that's died. That's according to the Department of Health website.
All right, so let's use that to segue then into a talk about the Swedish model for dealing with this and the concept of herd immunity. But let's start with herd immunity first. Can we clear this up? In my view, you're the doctor, but what I've been saying, and if I've been wrong, tell me, herd immunity is not a strategy. Herd immunity is a condition where a certain number of people, whether it's through natural immunity, whether it's through they've already had the virus, or whether it's through vaccinations, that enough people are immune where basically the disease dies out. Isn't that what herd immunity is?
In essence, herd immunity is to infectious disease medicine what gravity is to engineering.
Right.
I mean, it's a phenomenon. It's a fact.
Right.
Yes, exactly. Now there are some. See, unfortunately, what's happened in the era of mass vaccination and mass vaccination for appropriately deadly diseases, particularly smallpox, you had a disease eradication model. That requires mass vaccination programs. By the way, smallpox is infinitely more deadly than coronavirus, so it's appropriate. So you have the attainment of herd immunity under those conditions where you want to literally eliminate a disease, and that's effectively been done with smallpox, is you've got to get a herd immunity up to 70, 80, 90, 95%. And that model is what's being applied now to coronaviruses when people like the esteemed Dr. Fauci poo-poo the idea of herd immunity. Well, they're entirely different goals. The goal for something like coronavirus is to break the back of pandemic spread, of hospitalization and death. That's a totally different goal. And the immunity, the natural immunity may be augmented by a vaccine if there is a safe and effective one. The threshold to get to that point is a hell of a lot lower than 70, 80, 90%.
So to your earlier point about it not affecting young people and students and healthy people.
It's not that it doesn't affect them at all. It's that compared to seasonal influenza, it's a lot less deadly.
So my point being is not all spread is bad, right? If it spreads among healthy populations who 99.95% of them aren't going to be adversely impacted in a serious way, not all spread is bad. So counting every case is not the right metric, right?
It's ludicrous. It's ludicrous, and it's very expensive and wasteful. First of all, you could break it down even more sharply, and this state again is kind of proof of this. If you look, these are global data, but if you look at what's called a meta-analysis of all the studies that have tried to get their hands around what is the actual prevalence of the disease, how much is it occurring in populations across the world, you can't just do that by swab testing. You have to look for antibodies. Some would argue you should probably go beyond that, but at least it's estimated through looking at antibodies. People who've been infected maybe have been totally asymptomatic, and that's your denominator. Your numerator for something called the infection fatality ratio, not the case fatality ratio, which is a clinical measure. This is getting your arms around how many people are actually infected in the denominator, how many people actually died in the numerator, and putting aside my caveats about how we're determining death, but just accept those numbers. And now across the world, when you look at that number in people less than 70, it's 0.05%. It is 5 in 10,000. Okay, so that's telling you that there's a big pool of people where this is behaving, and I know this was a terrible sin to say back in the spring, but it's behaving entirely like the seasonal flu. And then there's the other side of the equation, where it's extraordinarily deadly, particularly in the frail elderly.
Mike?
So you can let the working age people, for sure, they must. We're doing them greater harm by locking them down, far greater harm. You can let those people circulate and develop a certain degree of herd immunity and try and shield and protect the truly vulnerable. It's an absolutely viable strategy. And in fact, it's the only strategy. It's the only rational
Well, that's
strategy
what
that we
Sweden is
have.
doing, and they've been dedicated. Mike, final question to you for the doctor.
Well, no, I'm getting a laugh out of this, and I got to be honest with you, because it reminds me of when we were childhood kids. You know, if one kid had chicken pox, your mother, you got thrown in the room with the person that had it, right? And so,
Well, we've also had major flu pandemics in 1957, 58, and 1968, 69, which, if you adjusted to the current level of the elderly in the population, even using a very crude way to do it, like just saying, you know, the number of people over 65, and then projected back onto those pandemics where there was absolutely no lockdown and none of the catastrophic economic and social consequences either that we've seen now, they would have lost about 500,000 people in the United States in adjusted to the current population and its demography in 57, 58, and about 300,000 in 68, 69, zero lockdown.
Wow. Okay.
So, you know, we've lived through this. We've lived through this when we were a different kind of country, quite frankly.
Right.
Not afraid of our shadow, right?
Well, yeah. Well, that's what this is what it's come down to. This
All
is,
right.
But the point is, it passed, and it didn't leave the sort of social and economic havoc, I'm afraid, that we're going to have with this.
So just to
let me ask you one question.
Go ahead, Mike.
Obviously, there's an alternative here, and listen, it doesn't matter what side of the fence you're on in regards to politics. In some aspects, this seems more politically driven with an agenda behind it. You know, and how can we not think this way? Are we off base?
It's hard to avoid coming to that conclusion, and that was I gave a simple example of that. You know, comparing how the governor reacted to that to that spike in August. And I'm not saying that the fall uptick won't get above, what it was in August, but there was no hint of this type of reaction back in August. And that was relatively closer to when she moved us, I think it was June 30th, if I'm remembering right, when she moved us to phase 3. So, it's a little disingenuous to go crazy now. And it's also, I think, very socially destructive for her to effectively dictate to people how they should spend their holidays and how their families should behave. And again, I get back to the mass testing and the quarantining of kids in the state. It's ridiculous. And the other thing that I've called for transparency on is it's a term. It's called the cycle threshold at which people test positive. It's a continuous thing. It's like if your doctor told you, and I treated lipid disorders in a specialized clinic in Rhode Island for a number of years. I couldn't just tell someone you got to take a statin drug because you have high cholesterol. Period. What's the number, doc? Well, it's the same thing about where you test positive. If you test positive at what's called a low cycle threshold, that means you have a high viral load, and that's much more serious and has potential consequences attached to it, hospitalization, infecting other people, than if you test at what's a high cycle threshold. So just to give you an example, a positive test at a low cycle threshold, where that means they don't have to go through many replications of the material in the specimen to show a positive test, that can be 2 billion copies of the virus equivalent at 12 cycles. Take that up to 38 cycles, and a lot of the testing goes up to 40 cycles. You're down to 8 copies. It's meaningless. It's absolutely meaningless. Yeah. And so many of these kids, I believe, that are completely asymptomatic, the college kids or the kids in schools, are testing positive at very high cycle thresholds where they're really not infectious, and they're certainly not at any particular risk. And we should know that. Each kid's parents should know that. The state should publish the data on this for all the testing. I mean, I don't know what have they done now? I think they've done hundreds of thousands of tests now. The state.
They're over a million.
This data should be.
Yeah, we passed a million tests. We passed a million tests.
We passed a million. Okay, so we should have graphs showing, okay, what's the percentage of tests that have turned positive at a cycle threshold less than or equal to 20, 21 to 25? 26 to 30,
Yeah,
31 to 35, and above 35. Because if we're seeing in kids and college kids, K to 12 kids, if we're seeing that the vast preponderance are testing higher than 30, or certainly than 33 to 35, I mean, leave them alone, for heaven's sake. Leave them alone.
All right, last comment. So to Governor Raimondo, who's going to talk to the state tomorrow about new restrictions because of this increase in number of cases, your direct response is?
Well, I want to see what the percent positivity is. Now, it's possible if you go to their website, you know, they supposedly they're supposed to be concerned when it gets at 5% or above. Okay, that's the percent that are positive. You know, if we're there, maybe she'll, and again, depending on what the specific restrictions are, maybe she'll have some argument. But if we're still hovering around 3% or 3.5%, then I don't understand if that's all that's driving this. And as I look,
well, just so you know, let me give you the data. Yesterday's data, our overall percent positivity was 2.7. First time.
Yeah, yesterday. I'm with you. I'm with you. I'm looking at it right now. 2.7% positive. 2.7% positive. You know, see, this is a very misleading. Go across and look at the quote new cases per 100,000 population by week. Okay, that we're already, you know, we're well above that threshold. If that's what she's going to invoke for doing this, that's bogus, because that is totally dependent upon her appeals for everyone to come forth from wherever they are and get tested. That's a bogus figure that's purely dependent on the number of people that are being tested, whereas the other figure is the rational figure. The percent positive, well, that's just the prior day, but prior week is a reason. And if you look on the same page, the threshold for that in the top graphic is greater than 5%. Now, I don't see how we're, based on these data that I'm looking at, unless something dramatic changed in the past. No, it's impossible. This is supposed to be literally the prior day. I don't see how we're anywhere near that. And that's the metric. Looking at the other metrics, I don't see any sharp rise in the important metrics, i.e. hospitalizations, ICU hospitalizations, or deaths. That actually should be what guides us.
Yeah, I've always
and
said
I don't see any significant change in those metrics.
All right, Doctor, we want to thank you for your very generous amount of time you spent with us today. Mike,
thank you very much.
My pleasure. My pleasure. I just hope Rhode Islanders start asking questions. And the first question they need to ask, since that's usually the entry to this house of horrors, is, okay, Doc, I feel okay, or I have a cough, I have a little sniffle. Well, you said I tested positive. What was my cycle threshold at which I tested positive? I want that number.
To educate people on that for sure. Okay, you're all right. Doctor, will you come back and join us again?
Anytime.
All right.
Thank you very much, Doctor. Thank you. Great conversation.
Take care. Bye-bye.